Childhood feeding problems are one of the most common complaints raised during pediatric primary care visits. This is not surprising given that the prevalence of pediatric feeding disorder is around 1 in 37 children under age 5. Feeding disorders overall are common in the pediatric population, with a prevalence of 25% of children in the general population and up to 80% of children with developmental disabilities. Unfortunately, many of these feeding problems are too often normalized, and parents are told to, quote, wait and see. When in reality, feeding problems may be associated with poor sleep quality, toileting problems, increased likelihood of medical conditions, or illness, ultimately leading to greater levels of caregiver stress and healthcare costs. The article that we are looking at today is a broad scoping review of research on pediatric feeding disorder, which really highlights the broad multidisciplinary interest in this disorder and feeding problems in general. After we review this article, we will welcome to the podcast Suzie Driscoll, an occupational therapist who started her own pediatric feeding therapy business, Tiny and Mighty. Suzie and I will discuss this research and its implications for OT professionals. So let's dive in. Welcome to the OT Potential Podcast, where we review new and influential OT journal articles, then invite on a guest to help us pull out actionable takeaways that you can implement in your practice starting today. Welcome to the podcast. I'm your host, Sarah Lyon, and I am a licensed occupational therapist. Before we dive into this topic of pediatric feeding therapy, I wanted to let you know that this podcast may qualify as continuing education for you. You are probably listening to this podcast on a free podcast platform, but to gain CEU credit, you will need to be a member of the OT Potential Club, our continuing education platform. So let's begin by looking at this journal article, and then we'll bring on Suzie to discuss how this research could play out in your practice. The article we are reviewing today is called Mapping the Gaps, a scoping review of research on pediatric feeding disorder. It was published in the Journal of Clinical Nutrition, ESPEN, and it was published in the year 2022. So the article begins with this introduction to pediatric feeding disorder, but before we go there, I just want to give a quick editor's note. In researching this disorder, I went deep down a rabbit hole, and please feel free to challenge what I've compiled here or reach out to me personally to let me know if there is something that I'm missing. Pediatric feeding disorder and feeding problems of childhood in general have a shifting terminology, so I'm doing my best to capture where we are at today. Pediatric feeding disorder is an umbrella term for pediatric feeding problems. It is defined as impaired oral intake that is not age appropriate and is associated with medical issues, nutritional factors, feeding skills, and or psychosocial dysfunction. Now, here's where this gets really interesting. And again, this was not in the article. This is my own research since this came out in 2022. So pediatric feeding disorder had its own code in the ICD-10, but I cannot find that same code in the ICD-11. I can find announcements that they were hoping it was going to be included in there, but as I'm searching the ICD-11, I personally just don't find it. That's really where my gap is. And again, feel free to reach out to me if you know more about this. But instead, the latest ICD-10 codes include codes for things like avoidant restrictive food intake disorder or feeding problems of the child or infant. So while the needs of this population have not gone away, the language and the coding is in flux. And with that, I'll bring us back into giving us an overview of this article. The prevalence of pediatric feeding disorders is high, rivaling the diagnosis of autism, and the diagnosis of feeding problems just continues to be on the rise. But much of the research remains siloed by discipline, warranting this new scoping review. So what was the intent of this paper? The purpose of this scoping review was to examine the extent, range, and nature of pediatric feeding disorder research between 2010 and 2019. So what were their methods? A literature search was conducted in September 2019 to identify empirical published research that included terms relevant to the pediatric patient population. For example, the words pediatric, children, infant, and adolescent, as well as those indicating a feeding disorder. So terms like feeding problems, disorder, difficulty, selective picky eating, swallowing disorder, dysphagia, and avoidant restrictive food intake. So what were their results? Ultimately, 415 articles were included in this study. The information from these studies was organized into 6 categories: characteristics, the purpose of the study, the design, the setting, the sample, and the measurement of feeding problems. I'm going to give a brief overview of the categories that are most relevant to clinical practice. As always, I encourage you to read this article in full for yourself. So looking at the characteristics of this article, a main point of interest in the characteristics section was the number of disciplines involved in authorship. This just really drives home the multidisciplinary nature of pediatric feeding. About half of the included studies had a multidisciplinary team of authors. Here's a breakdown of the first author disciplines and the corresponding number of studies. In psychology, there were 171 studies, in medicine, 123, nursing, 13 studies, public health, 8 studies, chiropractic, 3 studies, speech and language pathology, 45 studies, occupational therapy, 15 studies, physical therapy, 5 studies, and nutritionists, 17 studies. So SLPs had about 3 times as many studies as we in OT, but we did have significantly more than physical therapy, and we were right in line with nutritionists. Looking at the design of the studies, I think it is interesting to see the most studied intervention types. This list included behavioral with no functional analysis, 67 studies, parent training, 48 studies, behavioral with functional analysis, 38 studies, oral motor studies, 23, psychological, 16 studies, surgical procedures, 11 studies, sensory integration, 10 studies, and medication, 4 studies. What jumps out to me in that list is definitely surgical, and medication is at the bottom as the least studies. Really, the go-to, the most researched are these therapy interventions. Okay, next looking at the sample category, there is this really great graph in there that displays the age groups with the most studies. This is one I definitely encourage you to look at, but to summarize it in words, there is a big spike in research for newborns, and then it just really significantly drops off for children's ages 2 months up to 2 years, and then starts picking up again around 3 years. Again, this is really interesting, a little baffling to me because that transition to solids is such a critical window, and we seem to be really lacking in research around this time. Okay, on to the measurement of feeding problems. This probably feels the most actionable to therapists as these are measurements that we may use in our practice. I'm just going to say them out loud here in the OT Potential Club. I will link to the ones that are available for use and can be performed by occupational therapists. And I will put these in our assessment search, which then gives you the basic information about each assessment, like is it free, how long does it take to administer, and any other basic details about it. So the list that they have in here is Behavioral Pediatrics Feeding Assessment Scale, the Brief Autism Mealtime Behavior Inventory, the Children's Eating Behavior Questionnaire. There's one called About Your Child's Eating. There is a Food Frequency Questionnaire. There's the Children's Eating Behavior Inventory, the Queensland CP Child Feeding Questionnaire, the Mealtime Behavior Questionnaire, the Child Feeding Questionnaire, the Children's Eating Attitude Test, the Food Preference Inventory, and the Pediatric Eating Assessment Scale. And I should note that that list was in the order of frequency, with the ones I said at the top being the most commonly used. And again, that was the BAMBI, the Brief Autism Mealtime Behavior Inventory, and the Behavioral Pediatrics Feeding Assessment Scale. But quite a few found in these different research articles. Okay, headed into the discussion, one of the main gaps identified by the authors was the lack of studies focused on the role of caregivers in addressing feeding problems. This gap is noteworthy as the evidence suggests that pediatric feeding disorder impacts both the children and their caregivers, and that family-related psychological factors can in turn influence child outcomes. What remains to be determined is which pediatric feeding disorder treatment outcomes are the most meaningful to families and whether those outcomes are being measured in a valid way. Related to this question, the authors pointed to the diversity of measures used across disciplines, and it appears that in order to adopt a common set of measures and data elements, interdisciplinary collaboration and consensus is needed. The authors noted that well-developed parent report measures are some of the most pragmatic options for measurement, as they can be applied longitudinally across settings and do not require specific clinician training. So, headed into that final conclusion, as the prevalence of pediatric feeding disorder continues to increase, more rigorous and transparent research is needed. In order to support evidence-based and family-centered patient care, studies must consistently include variables that matter to families, such as child and parent quality of life. Okay, that research kind of gave us a broad overview of what is out there about pediatric feeding problems. As you can tell, this is an evolving practice area. More research is needed, but this is a problem faced by many children and many families. And clearly, therapy stands out as one of the most researched and that go-to for families seeking help. What this article did not answer for me, though, is what does it look like to be an occupational therapist practicing in this area? And I'm so happy that I found an occupational therapist who runs her own pediatric feeding therapy practice. And that is Suzie Driscoll, MOTOTRL. Suzie is a board-certified and licensed occupational therapist specializing in pediatric feeding therapy. She is dedicated to empowering families and little ones to thrive and enjoy mealtimes with confidence. Suzie graduated with a master's of occupational therapy from the University of Washington School of Medicine in 2016 and is a member of the American Occupational Therapy Association. One thing I want to note before I bring Suzie on is that you will hear that Suzie started her practice a few years ago and then pretty quickly filled her caseload. And when I hear that this has happened for an OT in private practice, I get really curious because I do know it is hard to start your own clinic and start getting that flow of leads and referrals and filling your schedule. So if someone is doing well, I always check on Google to see how they rank for their practice area in their specific city. And almost always, I find that the majority of successful practices have figured out how to be in the top of search for clients who are looking for that related service. So if you search Feeding Therapy Seattle, you will find Suzie right at the top next to Seattle Children's Hospital. So clearly, Suzie has done a great job connecting with parents looking for help in this area, and I'm excited to patch her into this podcast and learn more about her story. Welcome to the podcast, Suzie. It's great to have you.
Thank you, Sarah. It's wonderful to be here.
I am so glad that you are here. When there are problems in this pediatric feeding area, it just feels so important that we address them early because they can balloon into so many problems, as was outlined in some of the other research. And yeah, I'm just so passionate about helping kids get to people like you who can help address these problems. I'm so curious to learn more about you and how you got interested in this pretty specific area of occupational therapy. How did it all begin for you?
Yeah, gosh, I'm always like, how did it all start? I think officially it started when I started working at Seattle Children's Hospital. I took a few, trainings and continuing education that really kind of sparked my interest in this area. Before then, I've had maybe one or two guest lectures during OT school that kind of touched a little bit on feeding. But even at that time, I don't know, it didn't just spark an interest in me at that time for some reason. Maybe because, when you're in school, you're kind of learning all about everything, right? Being a generalist or just learning about, pediatrics, geriatrics, all the different fields. So yeah, when I started my job at the hospital in the outpatient side, I was just like, wow, like this is so much more interesting than I initially thought. So one thing led to another, and I just started, seeing more and more kids with their feeding concerns and who needed additional support. And I just got more and more into it. But kind of like a funny background, I was reflecting on this a little bit. How did it all begin? So kind of a funny story. Like in my childhood, I used to eat like cucumbers, right? It's like such a like specific example, but it's like it resonates with me. And one day I just didn't feel like eating, which is totally fair, right? I don't know exactly why, but I just was like, no, I don't want to eat cucumbers today. But my mom, like she force fed it, she's like, no, you have to. And I was like, I don't want to. So I'm kind of like the living example of why, force feeding can often backfire.
Yes.
Now I'm in my late 30s. I still prefer not to eat cucumbers. So that's kind of like, oh, wow. Okay. Like maybe that's kind of like my start to feeding therapy because I know exactly like how these kids feel when, you're kind of force fed something you just don't want to eat. So yeah, that's like my little background.
And I just like get a little peek into this practice area and I'm like, wow, what an incredible fit for OTs because eating is so multidimensional. Like you just alluded to, there's like family relationships happening there. There's all kinds of things that go into that actual feeding that I think OTs are such a good fit for. I think I also, off the top of my head, like back in the day, would have been like, that is a speech therapist domain. But knowing how complex all of our habits are, feeding is no exception, just such a great fit for OT. And I think this article did such a great job of just highlighting how many disciplines get involved and how that is just totally needed. So you're at Seattle Children's, you get this, which in my head, I'm like, that's a super cool workplace, and you get to see really great care happening there. I totally can see how you got exposed to really interesting therapies. But tell me about the step to starting your own business. That is a big step. How'd that happen?
Yeah. So I never ever thought I'd own a business. I'm a 1.5 generation Korean American. So I was about 10 when my family moved to the States. And I grew up watching them working really hard, around the clock on weekends. I was like, that is not the life for me. I'm going to be salarying. I'm going to just, do my job and then I'm gonna be all good. So I guess the joke's on me now. So even in OT school, like I was like, no, I don't want to be in private practice. That's like not me. But yeah, so going back to, how that kind of started, I think the first seed was planted when I had my own daughter in 2020. And we had our, fair share of feeding challenges when she was a newborn. So that kind of sparked an interest in me because, working at Seattle Children's, most of my, kids that I worked with were a little bit older, right? Maybe like the youngest was kind of starting solids, not being able to progress with their textures. And then like, all the way up to teens, if not a little bit older. So, yeah, I was just like, wow, this is such like an area that I never like had an exposure to. And it's so different when you're the mom, right? So yeah, that's kind of like how it all started. And then I, stayed there for another couple years. But kind of during that process, I just kept thinking more and more, like, what can I do, like, to help more kids, get support when they need it in the younger years versus, the majority of kids that I saw were, ages 8, 9, 10 coming to me and families would say, we've had concerns since they were 1 or 2. And everyone said, just wait and see. They'll grow out of it. This is just a phase. And I was like, how how, as a parent, like you just want your child to eat and grow and be healthy and, like how I am trying to find the right word, like not disappointing is not the right word, like how frustrating and invalidating that would have been. And what if someone was there earlier on and helped them kind of go on the right path so that they didn't have to navigate these, tough obstacles for many, many years until they finally were heard.
Mm-hmm.
Yeah.
Yeah, that's just goes beyond just feeding therapy or just like a really big picture disappointment I have with our current systems where I just feel like those earlier ages are underserved. Like I wish we could just put so much more focus at that 1 to 5 area, but it feels like in multiple areas that we try this wait and see method. And I guess I understand why that would happen back when we didn't have more interventions, but we do now. Like, why are we still in this wait and see mindset? Thinking of this article, the thing that stood out to me actually was there was this graph of the amount of research that was done at different ages, and there's a huge spike when you're newborn, and then it drops way, way low from between or right after newborn all the way up until about age 3. And I'm like, what in the world are we doing not researching this critical like transition to solids phase? I guess that's reflective of that therapy world out there where lots of times we don't get to see kids at that age. Yeah, that was my takeaway. What was yours?
Yeah. In a way, that felt very validating to me because that's like exactly the pattern I was seeing, right? Like, between like ages, kind of like, I think the article said maybe the majority of the studies were conducted between like 2 to 9 years old, I believe.
Mm-hmm.
So I'm like, all this time that was happening before 2 years old and like, kind of a typical selective eating phase kind of starts right around like 18 months. So that's like when it kind of all starts. Like if I could get a penny for every time I heard my baby used to eat everything and then it all changed, Yeah, so that really struck out to me. I was like, wow, yes, like this is exactly it. Like, why aren't we studying more, kids in this critical window where I feel like things get kind of cemented, both like for kids' oral motor skills and routines and, expectations and the, family dynamics. So I thought it was a really cool point that the article kind of highlighted.
Mm-hmm. Thinking of your practice, I'm curious, I guess a 2-part question, what the age is of kind of the majority of kids that you see, coupled with the main reason they come to therapy. I also liked how the article just kind of laid out all the different areas in this feeding problem category. Like it's a pretty big umbrella, and there's all kinds of reasons that could get people to therapy. Just for you in your corner of the world, what's the age and reason people get to you?
Yeah, great question. So the population that I saw while I was working in outpatient hospital setting and the population that I currently see in my private practice is a little different because of the age and kind of like the developmental stage, and, just the care model too. So in my current practice, in my private practice, I see babies as young as, couple weeks old. Currently, there's like a 5-year-old on my caseload, but majority would be kind of like couple weeks old. A lot of babies kind of like between a month and like 4 months old. And then from like 6 months all the way up to kind of 2 years-ish of age. So like for the younger cohort, like with the few weeks old to like 4-month-old-ish are often, babies are having trouble gaining weight. Their history often includes, they were not able to gain back their birth weight quick enough. They're having trouble, they're kind of falling off the growth curve. And, family is spending like the whole entire wake window trying to feed the baby because all they can do is really like take like couple little drops at a time versus ideally you want the feeding to be more efficient, right? Like they can, in an ideal world, it'd be like, 2 to 3 ounces in like under 30 minutes so that they can do tummy time and go on walks and all these other fun developmental things. But these families are like, we're literally feeding around the clock. And it's hard for all parties involved, babies and, caregivers. So those are kind of like the big issues. Of course, there's a lot of I'm trying to find the right word. There's a lot of correlation with like torticollis and plagioccephaly as well, and just kind of like lower tone. So there's like a lot of different things that are at play. Yeah.
And then the older cohort, that like 2 to 5, what are the common reasons you see them seeking out therapy?
Yeah, so that would be quote unquote the picky eaters, right? I'm always trying to find like the better way, but that's kind of like the most understood way to describe. So those kids often, their caregivers would say it's always hard to get them to sit down for meals, even for 5 minutes. Often like screens are used because that was kind of their last resort. But then now it's just become like a crutch, right? Like you have to have screen in order for, kids to take a few bites. And they would eat like less than 10 different types of food. Ideally, you want kids to eat like at least 30 different types of food. So when it's less than that, it's like, okay, I think, this kind of goes into the territory of being a little bit more nutritionally deficient, right? Often, even those 10, types of foods is like in one kind of group of foods, like a lot of like beigey, crunchy processed foods, and not like vegetables or meats, right? It's okay if, those are not your favorite foods, but like kids would often just like have, like aversion to them. Like they would just be like, absolutely. Those would be some of the common things I would see.
Yeah. I hadn't thought about the screen usage during meals. I guess my kids are just slightly older, but I can totally see that being like a added layer of challenge there. How do people find you versus other options? What do you think draws them to you?
Yeah, that's a great question. I feel like just OT in general still, I feel like, we're like lesser known, right? A lot of people are like, what is OT?
Yes.
Elevator speech and but feeding, and then like it's such like a niche. So I would say currently like a lot of my families find me through word of mouth or Google is a good, a resource for them, and other providers who I've connected with. They like understand the value of, OT and feeding therapy. So those would be kind of majority. I feel like pediatricians' offices often like are connected already to, like the Children's Hospital, for example, right? So I feel like majority of referrals currently go there. But then there's like long wait lists, right? Or, sometimes it takes forever to get back to them, or there's a lot of like back and forth communication. Like they can't get to the provider in an efficient manner. So I wish that was a little bit better too. So there's better awareness and access. Yeah.
Do you feel like you're getting the younger kids than you did at Children's because you're capturing like a group of parents that are just like highly motivated to get in there earlier? Or what do you think the difference is in your other outpatient?
That's a great question. I think that is absolutely right. Like parents are often tend to be more proactive, I think, especially when they're like young and, there's a lot, I feel like, speaking from personal experience, like when you just see this like newborn, you're like, they seem so helpless. You are just trying to make sure that they thrive versus an older kiddo is like, they can at least communicate somewhat. So I think there's a lot of urgency there. So I think they're just desperate to find any help, which is unfortunate. And I'm glad to be a resource when they're just seeking some sort of support. Uh, yeah, yeah.
Thinking of your initial evaluation process, I know you're seeing all kinds of kids with all kinds of different problems, so it's hard to summarize this. But just in general, when you're looking at evaluation, what are kind of like your go-to assessments, whether they're formal or informal? What does that just first session look like for you?
Yeah. Initially, I relied a lot on more like a formal assessment, but I found that sometimes it didn't apply to certain kids or families. It's great to have some objective, measurement or data, right? But I feel like feeding too in general is more subjective just by nature, right? Like we're not gonna like measure like how many ounces of turkey did you eat today?
Yeah.
That can create actually more anxiety. I feel like it goes into a different territory, or like you can't like you don't have a goniometer or what's the grip strength one? It's escaping my mind right now.
Dynamometer.
Yeah. Like you can't do that, right? With like measuring your jaw strength or, so at least with babies too, right? So over time, I found that, like I have my own process and like the symptoms that the families are describing, and what I'm seeing. So it's like a mix of some like informal measurement as well as like clinical experience that helped me kind of get the big picture.
Yeah, it's like this is an area that really lends itself to, if you can, like a quality of life measure for the parent. Like that feels like the most unifying. Like how much is this impacting your quality of life? That would almost be like a good go-to standardized assessment. And that's how ultimately you know if you're headed in the right direction. I'm pretty sure I read on your website about like a collaborative goal setting process. I love collaborative goal setting. So I just wanted to hear, like, what does that look like for you logistically?
Yeah. So yes, I think like OTs by nature are very like collaborative and want to have like, client and patient centered care, right? That's like, I feel like the heart of our practice. So how I like to kind of start like with that process is I just really hear what the family has to say about kind of like the whole feeding journey. Like they can take it all the way back, to like when baby was a newborn. Like it's always helpful. Even like sometimes like labor and delivery process, if there was any significant medical history there, those are all really helpful things for me to like think about in my, big picture kind of thinking process. And then kind of hearing their experience, we then kind of review, like what is your current like routine like, right? And like what does like a typical day look like, and like what are the feeding schedules? And then we kind of talk about our findings, and the child's or the baby's like strengths and skills, and maybe some areas that we can like work on for additional support. And then I just really value like what the family prioritizes. So for example, some families like kind of using my, majority of my caseload, like really, really wants to, nurse, breast/chest feed exclusively, right? So we talk about that and then kind of come up with some like realistic, achievable goals. And it can be like a short-term goal and a long-term goal. Or families are totally okay with combo feeding, like, a little bit of formula and a little bit of pumped milk or nursing. Like, so I just kind of like hear what the family really like values and feels like that would fit their like routines and lifestyle. Like it also, we have to take into factor if a parent has to go back to work from their, parental leave, right? So there are so many different factors at play. And we're gonna have, daycare in a month, starting in 1 month, or a family member helping, or, so many different factors. So I like to really hear what the family values, and then we try to set goals together that way.
Yeah. Oh, I think collaborative goal setting is important in every single setting that OTs are in, but especially thinking about pediatric feeding. And as we alluded to, how multidimensional it is and how personal it is, feels just critical to really lean into that collaborative goal setting skill set. Thinking about like treatment and interventions, what are your kind of go-tos, and which ones feel like the most potent to you? Like, oh, if I can do this, this has a high impact.
I think in any type of my treatment session, I always kind of go back to the just right challenge and therapeutic use of self. I think that's really helpful for, whether I'm working with like a 3-week-old versus a 5-year-old. And I have to kind of like match the energy, right? Like a 5-year-old would be like, let's go outside and play and like get some, sensory motor, experience, so that you feel more regulated and like ready for this task, versus like a 3-week-old. I have to kind of take into consideration like what are their current like developmental stage, right? Like, more like high contrast images to kind of help them like turn their gaze. So yeah, I guess the short answer might be it depends, but just kind of, thinking about, again, like, client or patient-centered, practice, and incorporating their family as well. And of course, like I need to also like work on, like, let's say like there are some oral motor skills that we can work on. So we work on that. Or like if there's any other like developmental, like a big thing, for example, for me when I see babies with some feeding challenges is that, again, like feedings take like the whole wake window, right? There's like no time for tummy time, which I totally understand. So often these babies would barely get any tummy time like during the day. And I think like my experience as a mom too, like I never want to make families feel guilty or bad, right? Because that's like the last thing I want to do. I just kind of say, oh, like, here's kind of what the AAP's current recommendations are. And I think we can get there, right? Here, every few minutes out. And like, I try to kind of guide them like to making tummy time more fun and how to incorporate it throughout their daily occupations, right? And just like give them, empower them and give them some tangible and hopeful things to work on versus like, oh,
Yeah.
Yeah. So I hope that kind of explains, some of my treatment, approaches and
The article talked about family involvement, and you just kind of alluded to that. But in your session, I assume with the newborns that mom's there and involved. As kids get older, what does family involvement look like for you?
Yeah. So that is a tricky thing when as kids get older, some of like routines kind of became somewhat cemented, right? So, like some of the less than ideal situations, for example, always needing like an iPad in order to sit and eat meals, or as kids get older, there are more extracurricular activities, right? Like soccer practice, and there may be like other siblings. There's just so many things at play here. So family dynamics, I think, changes in a way like their schedules just are a little bit more chaotic. And families, myself included, like at the end of the workday, you just want something that's like easy, like for the bedtime rush, right? Like there's no time to like do these like therapeutic activities, right? Like that we sometimes try to give us homework. Like I get it, right? So I think that's kind of the challenging part in our current kind of society, because it's just hard. Like all parents are just spread so thin.
Yeah. I'm thinking of generalist OTs, I'm in rural Nebraska and thinking about being an outpatient therapist here and thinking that kids with feeding problems might come to someone in my situation, to my caseload. What do you think a generalist OT, what are some of the strengths that they bring to feeding therapy? It's obviously an area that you can go very deep into and specialize in, but what kind of skills do we already have that we can bring if we happen to get these kids on our caseload?
Yeah. I mean, OTs have so much to bring to the table, right? And even in this area that ideally you need a little bit more, training and continuing education. And we already have the skills. So again, kind of going back to more of OTs being collaborative and, finding the just right challenge and, therapeutic use of self. And I think one of our big strengths as OTs, especially when it comes to feeding, is our sensory, our knowledge about sensory, processing and integration. So I think helping the child become more regulated and in a great state, that's a big step right there, right? And then I think just really I think feeding is such a intimate thing, right? You can't force someone to eat. You're not gonna stick a spoon in the mouth, right? And then they're gonna be oh my God, never again. So I think kind of starting where the child is comfortable and kind of we can, if let's say the goal is for the child to be able to have something that's rich in protein, for example, because they often go hungry or have trouble, maintaining their weight if they're falling off the growth chart. So let's say cheese, a stick of cheese. Initially, the child might be ew, I am not even touching that, string cheese. But if you make it fun and engaging, I feel OTs are so creative. For example, you can draw a face on a piece of paper and they're let's, kind of peel the string cheese to make cool hair. You can just be so creative and fun so that the child's oh, there's no pressure. There's no demand for me to eat. This is a fun playtime. And I don't know if you've heard of steps to eating, but we often think of eating as just you put something in your mouth and you chew and swallow, right? But there's actually so much more that goes into it. It's probably one of the more complex things our body can do. All our muscle systems have to work together, our organs and, nervous system. So I think taking a step back to, meet where the child is and, even touching and it's visual processing and tactile cues. It just helps the child be more comfortable with the sensory exposures. And maybe after 5 times of doing that, they might kind of be oh, let's make a little mustache with the string cheese. It's closer. It's just little steps. So yeah.
Yeah.
So I hope that helps.
Something I've always been intimidated by in the feeding world is it feels there are quite a few courses and approaches. And I know from looking at your bio that you've done quite a few of those. Is there one that stands out in your journey as that was really helpful to me at the time? It gave me lots of practical, informs the practical things I do today.
Yeah, gosh, there's so many good ones out there. But the very first one I took was the SOS approach to feeding. And that just really opened up my eyes. So I thought it was pretty comprehensive for someone who is interested in feeding, but they're not quite in deep in yet. Because it covers all the sensory motor, things and developmental, stages and what I mentioned with the steps to eating. So I think that's a wonderful place to start.
Thinking about this is such a common challenge for parents. Oftentimes it comes up in primary care visits, but there's just this delay in getting kids to therapy for lots of reasons. With kind of that background in mind, where do you hope we go for pediatric feeding? How do we help meet that need that's out there and being asked for, and it feels like there's not enough resources? Yeah, where do we go?
Yeah. I think so. Feeding Matters has a great screener, like I believe it's 6 questions, questionnaire, like screener, where I think would be really, really helpful in like that kind of primary care setting where they're doing like child checks, right? It's not just, oh, is your child eating? Okay, check, right? Like, yeah, off you go. As long as they're on their growth curve, it's okay, even though, it takes tremendous effort on the family's part so that, the child or the baby can stay on that, growth chart. So I think like going through something like a quick questionnaire, like, how you just do like a basic questionnaire, like at each visit, right? I think if that's integrated, that would be so helpful, at least getting that conversation started. And hopefully, then they can be referred to specialists who can provide help earlier.
Yeah, and even I've just been thinking a lot about making more public-facing therapy information and more like those self-reports, self-screens, making those more accessible online. Because why do we have to wait till we get to the primary care doctor? Like we can click through 6 questions online. And that's something they've just been thinking about big picture for our profession and helping to educate our patients before they even get to the doctor that they've already done that and they can ask it, or that they can do it. They've been referred to therapy and they can do more self-screens and show up with the information for us. Just feels like we have a lot of information and now the challenge is getting it in front of people at the right time and making it accessible.
Yes, 100%. Yeah, that questionnaire actually is available online, but not a lot of people know about it, right?
Yeah. How do we get people to that questionnaire?
Exactly. Yeah. Yeah. Oh man, gosh. Yeah. Like, do we need more? I don't know, like public health. Like, I don't know. Like, how do we do what? Yeah.
Do you know other OTs in private practice in the feeding therapy space? Yeah. How many of you are there out there?
Yeah, I know like there are lots like across our country, and we have, groups that we, stay in touch with and network with. It's really helpful. And in our kind of greater Seattle area, there are mostly like bigger practices that I know of, that have like 1 or 2, feeding therapists on staff. And, they may be like, feeding therapists where they can kind of cover like a wide range, right? In terms of feeding therapists, whether they're OTs or SLPs, currently kind of specializing in kind of like, toddler and under. I feel like there are only like a few of us that I know of. So it's definitely still an emerging area of practice. Yeah. Even for older kids too, I feel like there's just not enough. There are such long wait lists, and yeah.
I think that's the last question that the article just was making me reflect on is there are the different disciplines involved in feeding therapy. What does it look like to be multidisciplinary? I think especially for you where you're like in that solo outpatient private practice and not embedded in a larger organization. How can we still be multidisciplinary even in a setting like yours? What can that look like?
That's a great question. And that's something that I, really wanted to maintain as like a solo practitioner. So, I try to connect with like the referring providers. Like, for example, I often collaborate with lactation consultants who refer to me. So we always, with, permission, of course, like we always try to keep each other, posted on like, this is, I saw baby, A today, and this is kind of what, we worked on and I saw, and here are some of my goals and, what the parents are, working on currently. And vice versa. And sometimes there are other providers involved, pediatricians or pediatric dentists, other, therapists, PTs or SLPs. So I try really, it's one of the things that I really value, right? Teamwork approach. Of course, like parents are always involved too. That's like a given, I feel like. But I feel like it's important to mention. So I always try to keep like that line of communication open between all team members.
Mm-hmm.
Yeah.
Well, it's always fun to learn more about a practice area. This is one where I so clearly see the fit for OT. They so clearly see the need, thinking about the nutritional consequences of pediatric feeding problems just, makes this feel important, close to my heart. What is the final thing you want to share with us? I guess, especially thinking of anyone who's interested in this area. Yeah, what's your charge to those people?
Yeah, I think feeding can mean different things to different people, whether that's, by mouth or by tube or, by, breast or chest or bottles. Like, I think it's just so important to really like listen to what the family's priorities are and not your agenda, right? Just with everything too. And I found that different cultural backgrounds also have different practices and, routines and roles and expectations. Like what seems like the norm to our society is not what it's like for other families, right? And I feel like I'm fortunate to have a little bit of taste in that with my, Korean American background, because like certain things are different, right? But certain things are also kind of universal where, I was expected to finish everything on my plate. So I think it's really important to have that in mind and know that, OT is definitely, like feeding is an ADL, right? It's an activity of daily living. So it's definitely within our scope of practice. So I hope we continue to grow and represent well in this area as a profession.
Yeah. Well, Suzie, I so appreciate you taking the time today to just share about you and your approach to feeding therapy. Like we've said multiple times, it's so important. And so I appreciate the time today and also just the work that you do.
Thank you so much. It's been an honor to be with you and your listeners.
Thank you. Wow, you all, this topic really gets me fired up because there is clearly such a need here, but it feels like there is so much work to do in working towards a common language, common assessments, and just common messaging about the importance of pediatric feeding therapy. At OT Potential, we are working on a clinical decision support page for feeding therapy. These clinical decision support pages are intended to read as menus of evidence-based assessment and treatment options that therapists can choose from based on the needs of their particular client. It is our goal always to have two versions of these pages, one for clinicians with quite a bit of detail on what these different assessments and treatments could entail, and then one that is public-facing just to help educate the public about the services that OT provides. I don't think we will have this page done in time to come out with this podcast episode, but we are working on it, so please watch for it to be announced in our newsletter. And also related to this, we are looking to try a new format for our podcast in this upcoming spring, and we are looking to feature a panel discussion that talks about big picture questions for our profession. I'm feeling like this is a necessary step as we just have so many questions to navigate together in a quickly changing healthcare environment. So examples of these questions might include things like, what is the future of the diagnosis of pediatric feeding disorder? Or how can we connect more children to feeding therapy? So I hope you just continue to tune in and join us as we try these different formats and the best way to get the information to you. I am really excited. My brother-in-law, who wrote for SNL and just has a great mind for crafting engaging conversations, is going to be helping me format these panel discussions. So we're really excited about them and excited for you to continue to tune in. And lastly, I did want you to know that if you are looking for a CEU certificate for your time today, what you are going to do next is head to otpotential.com and either sign in or sign up for the OT Potential Club. Once you are in there, you can take a 5-question test, and when you pass, we will generate a certificate for your time today. Okay, I want to thank you so much for joining us. I hope this podcast helps keep you informed and inspired as an OT professional. Take care, and we'll talk next time.